Welcome to the Electronic Health Records Breakout Session 2, leveraging EHR data to understand healthcare utilization and health outcomes. All right, I will introduce myself, and then each of the presenters will introduce, I will introduce them before their presentations. I'm Pei Hong, and I'm an assistant professor at the University of South Carolina, Arnold School of Public Health. It's really a privilege to moderate this excellent and very informative session of 5 presentations. But I will explain a little bit. We will now have 4 presentations. Panelists in this session will discuss various approaches and issues tackling electronic health record data or electronic medical record data in the efforts to elucidate the variations in healthcare utilization and a few of them patient outcomes in a large health system, in a state, and nationally. And one of our presenters, Ms. Chelsea Norgard, is unfortunately ill and not able to join us today. It was bad news. But good news is that Ms. Norgard will be recording her presentation after she feels well, and it will be made available for you all until May 12th, like within 30 days of the conference. Another good news is that we will have more time to enjoy and having the conversations and Q&A session with the other 4 excellent presenters. Each presentation will take about 20 minutes, followed by up to 5 minutes Q&A, if any. We will have an overall Q&A session after all presentations. Feel free to type your questions in the chat box while the presentations are ongoing. All right, let's get started with the first one. Our first presenter is Dr. Jihong Liu. Dr. Liu is a perinatal epidemiologist whose research focuses on obesity, pregnancy-related complications, healthy lifestyles, access to care, and health disparities among mothers, infants, and children. Among many projects, currently Dr. Liu is leading an NIH-funded study to examine the roles of social context on racial ethnic disparities in severe maternal morbidity and mortality in the context of COVID-19, using the large population databases in South Carolina and ongoing in the United States. Dr. Liu just completed another study to investigate the impacts of the COVID pandemic on mental, physical health behaviors, and access to healthcare among pregnant and postpartum women in the United States. Today, Dr. Liu will be sharing with us one of her studies on the impact of the COVID-19 pandemic on racial ethnic disparities in severe maternal morbidity. Let's welcome Dr. Jihong Liu.
Thank you so much, Dr. Han, for excellent introduction. So you can hear me, right? Okay, let me share my slides first. Can you see my slides?
Yes.
Okay, that's good. Yeah, so my name is Jihong Liu. I'm a professor of epidemiology from Arnold School Public Health. Today, it's my great pleasure to have this opportunity to present our preliminary findings from our NIH-funded study. We look at the impacts of COVID-19 pandemic on racial ethnic disparity in severe maternal morbidity using South Carolina data. So before I go into the presentation, I want to first acknowledge a funding source from NIH and also a pilot project program at Big Data Health Science Center at U of SC. I also want to acknowledge my co-authors. Dr. Han is one of the co-authors on this paper, and also Dr. Jaja Zhang and Dr. Campbell, etc. All those folks are part of our project team. Before I move into the severe maternal morbidity, I want to give you some background why we chosen this topic, and then what's the current status before we move into the pandemic one. So every 12 hours in United States, a US family loses a mother as a result of the pregnancy or due to the delivery complications. And maternal mortality has been increasing in United States in the past decades. And then also compared with other developed countries, the maternal mortality ratio in United States is higher than other, developed countries. Therefore, it's become an interesting issue to understand how we can reverse these trends. Severe maternal morbidity at delivery hospitalizations actually contribute a third of the maternal mortality. And the latest paper showed it can be even higher if you include in the severe maternal morbidity in other time periods, like pregnancy or postpartum. Therefore, this severe maternal morbidity holds the promise of reversing these rising trends in maternal mortality. So then what is severe maternal morbidity? It's kind of an unexpected and serious labor and delivery outcomes, and they're also known as near-miss events that could result in deaths. So far, based on estimation, is outdated data in 2014, in United States, estimated, the severe maternal morbidity at the delivery time impacts about 50K to 60K births every year. So this trends to show from 1993 to, let me just move my slides a little bit. Yeah, from 1993 to 2014, severe maternal morbidity rates has been tripled. From 46 something, per SSM cases per 10,000 deliveries increased to 140 in 2014. So this is not surprising. It's consistent with the maternal mortality. And then the other one, you can see most of this increase in is the mimic really well with the blood transfusion. And then other type of indicators is increased slightly, but it's not as dramatic as the blood transfusion overall rates. We also know there's a strong relationship between severe maternal morbidity with the race, ethnicity, age, region, and the community level income and hospital type. So on your left side, we present some data which was published in 2020 to show there was a racial disparity in SSM. Among non-Hispanic Black, the SSM rate is 226. And which is almost double what is raised in the white people. And then second for age, women older than 40 years old has the 246 SSM cases. And then by region, it was the highest in Northeast, followed by Southern states. And in terms of the community income level, it was the highest among those who live in the lowest quartile or the poorest, community. Further, the SSM rate is also higher in the hospital, which is a public, ownership. So the etiology of the severe maternal morbidity is very complex. However, the data from previous slides indicates, the social determinants of health framework can be a good model to examine the causes and determinants of the severe maternal morbidity. It's important, it indicates it's important to look at it, take a multi-domain, multi-level approach to understand the severe maternal morbidity. During the COVID-19, due to this long-standing inequalities in access to care, education, unemployment, and lack of home ownership, and disadvantaged neighborhoods, the women of color lived in, we assume, during the COVID-19, this that we will see the widening disparities in exposure to the COVID-19 infections, to COVID-19 related hospitalizations and COVID-19 deaths. Because of that, we might also see this COVID-19 pandemic may exacerbate the disparity in severe maternal morbidity. So our colleagues at USC, we submit a grant to NIH. We were funded to conduct the multi-level determinants of the racial ethnic disparity in severe maternal morbidity and the mortality in the context of COVID-19 pandemic. Our specific aim is, looking at this racial disparity in SSM and also other contributing mediating pathways, more focus on social, contexts. So today I'm going to present one aim from that, the grants we funded, and specifically we'll focus on to look at impacts of this pandemic on racial disparity in SSM in South Carolina. For a funded study, we also is going to look at national electronic medical records data. So far, our results there is not ready to share yet. So here's our hypothesis. Compared to the pre-pandemic time, severe maternal morbidity has increased, and then also race ethnicity disparity in severe maternal morbidity has widened during this pandemic. Second is compared to the women without COVID-19 infection, the women with infection has a high proportion of severe maternal morbidity, and racial disparity in severe SSM have amplified among women with a COVID infection. So where our data come from? In South Carolina, we really, have a very supportive environment in terms of getting real, work data. So we have a revenue and a physical files. They have a state data warehouse. This data warehouse basically create an integrated data system to link in the data from multiple government agencies or programs. They be able to pull data together. So for this specific projects, we've taken the data from claims system, from all payers healthcare database, health departments, and then disease registry. This project started from Dr. Lee and Dr. Altoff. They got funding from AID to create a South Carolina COVID-19 cohort. We abbreviated as the S3C data. And then they create a partnership with the South Carolina, Big Data Health Science Center, with the DHAC, which is our health department, South Carolina RFA, and other state departments. And what they do is integrate the patient's EHR data with other real-world data, which is shown in the previous slides. So because during the COVID-19, the another real-world data is statewide COVID-19 testing data, in addition to hospital discharge data, large insurance data, and L resource file. So what we do is through this new funding mechanism, we be able to expand that S3C to the pregnancy cohorts. And we create a S3CP, which is longitudinal linked database. So in the middle, the yellow circle to show the core of our data linkage, which is birth certificates linked with hospital discharge data. And then we focus on 2019 to 2021. And then in order to create this longitudinal data, we include all women 1 year before they, pandemic, what's their, health status from, the hospital discharge data and healthcare utilizations. We also extend 1 year after, this period. So therefore, we have a data, conception, delivery, and 1 year postpartum. So we link in other type of data during the pandemic, COVID-19 testing data, insurance claim data, and then fetal, child, and the maternal death file. Think about our goal is the severe maternal morbidity and mortality. We further add the contextual data. The contextual data is richer than what earlier said, the Ehr resource file. We also add access to obstetric hospitals, the county level, COVID-19 severity, social distancing policies, and telehealth services expansion. We are still in the process to get electronic data, electronic medical data linked to our database. So in the future, we'll have even richer data. So this S3CP, including all the women who had childbirth between January 2018 to December 2021. And then for this specific analysis I present today, we included women who gave birth between January 2018 to March 2021. The later data is not quite ready yet, so we just cut off that time. We exclude the women who give birth less than 20 years gestation and women who terminate pregnancies, such as abortion. So what is actually SSM? So this one gives you a very detailed list of the conditions included in this composite of SSM. We apply the CDC algorithm and using the SD10 and then DRG codes to identify these 21 conditions. So in today's presentation, we only focus on the SSM at the delivery time for that hospitalizations. I highlighted, blood product transfusion as the one major ones. So how we define the pandemic and COVID-19 infection measures. So pandemic effects is just like a time periods. We defined the pre-pandemic period is January 2018 to February 2020. And then peri-pandemic started from March 2020. And then because the COVID-19 testing data, we'd be able to know whether women is tested or not tested. And then further, we have this COVID-19 infection variables, which is actually assessed multiple domain. We look at whether women is positive or not. Positive here is defined as confirmed cases and probable cases. And negative is a negative testing results or suspected. And we also, based on the symptoms the women reported on the form, to categorize those cases into asymptomatic cases, mild symptoms, or severe cases. Further, because it's a pregnancy, related pregnancy outcomes, we'll look at the timing of the, first COVID-19 infections in terms of whether it happened during pregnancy or childbirth. Lastly, we look at how far it's away from this delivery hospitalization. If it's less than 90 days, we say it's around, later pregnancy. If it's greater than 90 days, it's kind of early or mid-trimesters. So we have other variables considered in our analysis. The major one is race ethnicity. And we consider, the access to care, such as a primary insurance payer, whether they initiate prenatal care in first trimester, and other socioeconomic ones, such as maternal education, whether they participate in WIC program is a nutrition supplement program. And then we include in other behavior and then biomedical factors such as BMI, smoking, and then the previous, history of having, adverse outcomes, such as the cesarean delivery, diabetes, hypertension, and preterm birth. We also be able to categorize gestational diabetes, gestational hypertension. Further, we consider the living environments by consider urban, rural, residents for the mother, and then look at the perinatal care level for the delivery hospitals. So in broad way, we trying to apply that the social determinants of health model. So statistical analysis, bivariate analysis using chi-square test for categorical variables and t-test one-way ANOVA for continuous variables. For model results, we use a multi-level logistic regression model with the random effects at the delivery facility sites and trying to examine the differences of SSM by pandemic periods, by COVID-19 status, by race ethnicity. And then the adjustment variables are shown in the previous slides. So here's our preliminary results. First, I reported what is our sample size. Using the definition pre-pandemic, we included 102,000 women, which gave birth to 106,000 births. And then 98% of them are delivered in hospital. And then 1.4% are delivered in other settings, can be home births, etc. But during the peri-pandemic time, we including 52K women and 65K childbirths. And we see the increase, percentage of the births actually delivered in other setting, which is 3%. So this slide just show you what the other characteristics of women in peri-pandemic time in terms of racial profiles, compositions. So on your left, it shows, among those women who did not have any COVID-19 testing, 33.8% of African American. And among those who got a negative or suspected, results is 29% African American. But among those confirmed, a probable case is 35.8%. So the chi-square test show those is, kind of a significant relation with the race ethnicity. And we don't quite get time to really show you what's the percentage of the test positive by different race groups. So indicates, it seems like a African American have a high, rates to being tested positive. So this show you SSM rates by pandemic periods and also by COVID-19 infection in South Carolina. The data presented as the number of the SSM cases per 10,000 births. And on your left side, we present overall data before stratifying. So we lump our data into 4 categories, pre-pandemic period, peri-pandemic and no testing, peri-pandemic and testing negative, peri-pandemic test positive. So you can see pre-pandemic is 177 and peri-pandemic no testing 174. So they're almost the same. And those, test negative are 178. But we see those peri-pandemic and test positive, the SSM rates is 312. So that just indicates COVID-19 testing positive may have, impacts on severe maternal morbidity. So then we split down by the raciousness group. Among whites, if women who test positive is 251 severe maternal morbidity cases over 10,000 births. And this rate is even higher among non-Hispanic Black, which is 378. Hispanic is 402. And then this last one, sorry, my printer, my computer is so blocked, is 333. This one just answer our questions. Is this racial, disparity in terms of SM rates over time? Is this, widening? So as you see from this chart, what we'll find is the black one is the black one is African American. So we can see African American severe maternal mortality rates is always higher than the white. White is red color. And we didn't see clear pattern. The straight black line show when the pandemic starts. So there was no clear pattern to show this, racial disparity magnified in the post and peri-pandemic periods. But the racial disparity persisted. So here's to show you some results from the models after adjusting for all covariates in the model. First one, is for this pandemic indicator. Again, it's consistent with our raw results. There was no, increased SSM rate in pandemic period. And the racial disparity is the non-Hispanic Black women has 1.84 times higher of odds to get the SSM compared with the white women. And the same, odds ratios for non-Hispanic others compared with the whites. And then this further look at the combination of the COVID-19 testing. So on your left side, we see that 2.25, which indicates if women who are living in peri-pandemic periods who test positive, they have a 2 times higher odds to get SSM compared to women who live in pre-pandemic period. On your right side, we look at the severity of the COVID-19 testing. So we see the odds ratios greater than 1, but they're all not significant. Further, we're looking at the timing of the COVID-19 testing. So we show that if COVID-19 infection occurred or diagnosed during the childbirth, women have a 2 times higher odds to get SSM. And similarly, if the COVID-19 was tested in the later trimester of the pregnancy, they have about 2.8 times higher odds to get a severe maternal morbidity. Okay, so in conclusion, we find that there was no significant increase in severe maternal morbidity in early pandemic compared to pre-pandemic. So why I call early pandemic? Because our data was cut off in March 2021. So we know the pandemic is still ongoing, and there was a 9 months data, so we're going to add them there. Second, compared to white women, SSM rates were 1.8 times higher than non-Hispanic Black women, among non-Hispanic women, and among women of non-Hispanic others. There's no significant difference between white and Hispanic women in SSM. And the racial disparity in SSM did not change significantly in peri-pandemic periods. Finally, and most important, findings is COVID-19 infection, especially infection in late pregnancy and childbirth, were associated with 2 times higher odds of severe maternal morbidity than women without any infection. So our future work is continue to refine our analysis by adding maternal mortality and also examine severe maternal morbidity in pregnancy and postpartum. We will also apply the social determinants framework to examine other multi-level risk factors for severe maternal morbidity. And we will examine the impacts of the severe maternal morbidity during pregnancy or at delivery on other long-term health profiles in postpartum. I'm sorry. So Thank you so much for your time and interest. Looking forward to discuss with you more about our findings.
Thank you, Dr. Liu. If you have any questions, quick questions, feel free to put in the chat box. And when we are waiting for questions coming in, I just want to use this opportunity to acknowledge that our program officer, Dr. Rosemary McKay from NIAID, and the Chief of Epidemiology, Dr. Colleague Williams, are here with us. We want to thank you for your strong support to our research. Thank you. Right. There are a few questions here. Michelle asked about, Dr. Liu, it's in the chat box. What was the ratio for pre and low and post? I bet post-pandemic. There doesn't seem to be a significant difference due to the testing positive for COVID.
I was not clear what is the kind of a ratio is asking.
Maybe a severe maternal morbidity ratio?
Oh, this 1.1, right? That the pandemic one odds ratio is 1.1 was not significant.
Yeah.
Yeah, did you consider?
And the second question we have from James Matthews, did you correlate finding to whether they were covered by insurance? Was you included insurance type?
Yes, we did include an insurance type. And then also, some of you, may know for during pregnancy, any women without insurance, they can get insurance through the Medicaid. So that is a part of, access to care, is not major issue. At least at delivery time. And maybe at the beginning, they don't know they can get a Medicaid, they need assistance.
There's one more question, one more minute for the question, and we can cover all the rest of the questions. Nate asked about, great presentation, Dr. Liu. Just curious, there were a few time points where the disparities go to 0 depending on the month. Just curious as to why that might be.
Oh, I think it's a severe maternal morbidity. Probably, it's rare events. And for those specific, when you look at the months, it just got a 0. And in order to solve this problem, we're trying to do 2 months, average rates. Yeah.
We'll leave, save those very good questions at the end after all the presentations. Thank you. So our next presentation is presented by Dr. Richard Jordan. Thank you, Dr. Liu. Dr. Jordan is a principal data scientist and algorithm developer at Health Data Analytics Institute in Massachusetts. Since receiving his PhD in mathematics at the University of Massachusetts in 1994, he has held numerous positions in academics, national research labs, and in private industry. At Health Data Analytics Institute, Dr. Jordan's work focuses on the applications of machine learning and data science to the prediction of patient outcomes. Dr. Jordan will be presenting his project, the use of importance sampling to improve generalization on the covariate shift for predictive models built on EHR data. Let's welcome Dr. Richard Jordan. Richard?
Hi, thank you for the introduction. Let me share my screen. Did that work?
Not yet.
Here
we go.
There you go. Okay, so let me enlarge that. Look good? Does that look good?
Looks good.
Okay, actually, I want to do full screen, right? There we go. Yeah. So it's a long title, so I won't repeat it. But the basic idea is how do you deal with the fact that the data that you might be training your models on is different from the data that you might eventually be applying them to. And so just go ahead with that. So let me give just a brief background on our company and what we're doing. We have access to Medicare data going back many years. So national Medicare data, millions upon millions of records for patients, including their diagnoses and their any procedures, hospital admissions, just millions upon millions, just huge data set. And we're working with various hospital systems to try to use this data to predict outcomes for patients and to help them target patients that may be at risk for certain outcomes. And I'm really excited to be presenting here because I would really, one of the things I'd be really interested in is working with people in academics as well. So yeah, that's the basic setup. And one of the issues is with the adoption of electronic health records in the healthcare system, there's this promise that you can use AHR to have really accurate predictions of patient outcomes, mortality, sepsis, respiratory failure, you name it. So that's a big promise, and it's pretty exciting. There's a lot of hype about using AI and machine learning. But there are these huge disparities in demographics from, say, one hospital system to another. There's also data quality issues. There's standards in clinical practice that might vary from one hospital system to another. And these result in covariate shift. So covariate shift just means that the distribution of the data that you might be training your models on is different from the distribution of where you might be applying them. And that can severely hurt the generalization of your models. And the problem with that, of course, is that, if you work with a hospital system, you say, oh, we developed these models and here's our AUC of 0.93, and now you get their data and your AUC is dropped to 0.78, that's really bad, right? It can result in the distrust of machine learning and your predictive models and really hinder the chances of adoption. There's a lot of sort of skepticism out there, probably as much as hype that's out there. So we have to develop models and methods that are robust under covariate shift for metrics that are clinically important. I'm going to talk about AUC, area under the curve, today, but obviously there are all kinds of other metrics that are important, sensitivity and positive predictive value, net benefit. There's a lot of different metrics that we should be looking at. Ideally, what we want from our perspective as a company is we want interpretable models such as logistic, but we do compare to gradient boosted ensembles, random forest, neural networks, just to sort of get a baseline. And, as someone from a machine learning background, of course, I want to have my fancy gradient boosted models deployed. But the fact of the matter is that when you talk with clinicians in these various hospital systems, they might be comfortable with logistic, but they're not, because there's the interpretation with the that comes from the coefficients and odd ratios. So, which reminds me of this quote, and and this seemingly is I see it all the time on Twitter and the AI and ML sort of corners of Twitter. It's just, when we raise money, we call it AI. When we hire, we call it machine learning. And when we do the work, it's logistic regression. There's a little bit of truth to that. It's not entirely true, but it is really important to have interpretable models. So I'll get in the next slide, I'll get into the details of the data sets and how we, what's involved for variables. But let me just show you an example of the data set shift in a few ways. So here's the data that we're training on, and we're going to be applying to data from Utah and Oregon, specific data that we got for test. And I'm just showing here distribution of the age. And so we can see that the training data has a high shift towards older age. It's basically Medicare data. It's not all that surprising, but it shifted towards higher age. When we look at the Utah data, it has a peak at high age, but it has a peak at lower age. And then the Oregon data actually doesn't go up higher than 70, 72, I think. But we did this intentionally because we wanted to actually get a sample of data that would be different. Now, diagnosis counts, that will just be the ICD code. And actually, in this case, it's CCS mappings, CCSR mappings of ICD codes. But here's the counts of the number of diagnoses that we see per patient, for each patient. And we can see that based on the CDFs, the training data has a lot more diagnosis codes than Utah and Oregon, which probably isn't surprising based on the age. The older individuals probably have more. But what's kind of interesting is the flip with the Utah and Oregon. Whereas Utah has a peak at higher ages, it actually typically has the lower diagnosis counts. So part of this could be, there's lots of ways that there can be problems with the data. It's not just demographics. It could be just bad data. It could be different coding practices. This is all the things we need to consider. And just a breakdown of the male and female, we can see that these are different as well in the data. Okay, so excuse me, the details on the data sets, I'm going to look at, I'm using a 5% sample. We have access to the full Medicare, but just for this, I'm going to use a 5% sample of Medicare admissions data. And this includes patients from age 18 to 99. We cut it off above that. Variables used for predictors are age at the time of admission, whether or not someone's a male or female, and then the clinical classification software mappings of the ICD-10 codes. So basically it takes the tens of thousands of ICD codes and maps them down into categories. And I wanted to do this just to have fewer variables to illustrate. We do use the ICD-10 codes as well, but in this case I won't. And I'm looking at, for each of those 525 codes that we have, I have the variables are a binary indicator at the time of admission. So what was the admitting diagnosis? Binary indicator for a code within 90 days before admission, and then within 365 days. So we're looking at 1,575 variables there, plus the male or the female indicator and age, which we keep as continuous. So that's where the 1577 comes from. We got data, as I said, from hospital system in Utah and hospital system in Oregon. And the data is defined exactly the same as above, except we see that there's big differences in age distributions and male-female distributions. And but the Utah data is 64,000, roughly 64,000 records and 1,577 columns, same as before. And what I'm going to be doing is I want to be predicting an outcome, which I call an endpoint, 90 days in the future from the admission. So whether or not someone is diagnosed with a condition 90 days in the future after admission. Oh, and I should say that probably the racial and ethnic breakdowns in the test set is very different from training. But that information is actually missing in our test set, so we don't use racial information, race and ethnicity. Okay, and just sort of to get started, a lot of the variables are not useful, and so I, do run an initial variable selection method, just using gradient boosted trees to rank variable importance, to limit it down to 100. Nothing special about 100. Just something I did just to keep things tractable. And I should say that other methods, I did all kinds of other methods, and they all roughly give the same 100 for each endpoint. So, yeah, so what just sort of formalize what covariate shift is. So basically what we know is the distributions, if you think of the joint distributions on the source set and the target set, they're different, and they can be different. In the cases we're looking at, they're very different between our source or the training set and the target or the test sets. So this is the basic underlying assumption, they're different. Now, the covariate shift assumption is that it's only the distributions of the covariates of your predictive variables that are different, whereas the conditional distribution of the dependent variable given your covariates is the same. So that's a big assumption, actually. And, you know, it is plenty of evidence that it's not really true in our situation. However, it gives us a starting point and see whether or not we can still do something under that assumption, right? So the basic, you know, importance sampling is based on it's now kind of a classic result, that if the training and test distributions were known, then the classification loss on the test distribution will be minimized by weighting the loss on the training distribution with an instance-specific factor, which you call the importance weight. It's just the density ratios between the target and the source set. So effectively, if you knew the densities, you could just find these densities. You could then just, when you build your model, you can weight the data points according to the density. And you can't do any better than that, right? I mean, it would end up giving you the results that you want. That will give you the optimal loss. And in the context of logistic regression, this really is just weighting the log likelihood for each data point in the training set. So what it's really doing is just going to put most of the emphasis on the points that look like things that look like data points in the test set. Okay? So the assumption we're working under is that, and I think I'll get to it in the next slide, so let me go ahead. But there are a couple practical difficulties here. We don't really know the joint distributions of the covariates on the training and test sets exactly. What we do have is samples, so we can try to estimate them. However, density estimation is notoriously difficult, especially in high-dimensional settings. And when you have variables that are binary and continuous combined, it becomes very difficult. So there is an approach that gets around this that's pretty simple and makes intuitive sense. And that was proposed by Bickle and co-authors in the reference I put down below. But the basic idea here is that you can get estimates of the probability that a data point belongs to the training set versus the test set by just building a discriminator to distinguish between the two. So formally what you do is you take a matrix X whose rows consist of the training covariates, and then you add to that the rows that consist of the test covariates. So you have a big matrix it's combined. You have a binary variable that you define to be 1 if a data point is in the training set, and 0 if it's in the test set. And then you build the probabilistic model to predict, right? So the classifier model estimates probability that y equals 1 given x, in other words, the probability that data point belongs to the training set. And then the probability that it belongs to the test set is just 1 minus that. And then your importance weight is approximated by this ratio. Okay, so that's the idea behind it. And then, you know, given the estimates for the importance weights for each endpoint, you just train a weighted model on the source training data, where you have weighted the training points according to this density ratio. And in this case, you use that weighted model to predict on the target test set. And I'll illustrate this in the context of a logistic model. So there is a very important assumption here, and it's that we do have test set covariate samples, right? So on the other hand, we wouldn't have necessarily the test set endpoint outcomes at the at our disposal at the time that we want to deploy the model and develop the model. And this actually is a setting that we're confronted with at HDAI. So, you know, we can build these models on the Medicare data, but then we want to actually go apply to a new hospital system. And they may be able to give us a history of diagnoses, but we may not have the outcome yet, you know, because we're predicting things that are going to happen in the future. So we may not have the outcome until after we actually want to try to deploy or at least develop the model. So this is a setting that we definitely are confronted with. Okay, so there's another approach I'm going to show you results for. And one of the issues with the importance sampling is that it can end up putting too much weight on a small number of points, right? So if we're looking at the ratio and we're doing this weighting, if it ends up putting a large, if it ends up having a very small ratio here, a very small denominator, then it's going to end up actually putting all kinds of weight on a small number. If that happens for a small number of points, it could put almost all the weight on those points. And then your model is just focusing on those points at the exclusion of other points. So you can fail to capture a majority of points accurately. In the literature, there's ML literature, there's heuristics that say you clip the weight. But those are really heuristics, and it's hard to know how well they work, you know, and it's hard to know how to clip them. And it's all sort of hand wavy. So there's a very recently proposed approach which does something that should be more robust. And what you're doing is you do the same approach as the importance sampling. You do the discrimination to get the probabilities that a data point belongs to the target versus the test, the training versus the test set. But what you do instead of forming the ratio is you just stratify based on that prediction, right? So you stratify according to the quantiles of the probability that a data point belongs to the source set. And so, for example, you might stratify into 5 different intervals based on quantiles 0 to 0.2, 0.2 to 0.4, etc. And then you would train logistic models on each one of those strata and then combine them in the end. So what I'm going to do here is use just 5. And the idea is this will avoid the small denominator issue. However, obviously we'll give up resolution because we've discretized. Okay. So with all that said, let's just jump into some results. Okay, so I have some backup slides where I say exactly how these models are defined, or the endpoints are defined. So you can take a look at that, but they're based on ICD-10 codes and, you know, looking up to see whether or not there's already, you know, accepted definitions in the literature or according to CDC or other sources, and then just mimicking them, and then we define them based on our data. And so here's an example, and I'm going to look at the ordinary regression. Remember, we're predicting these 90 days out. Importance weighted logistic, and then the propensity stratified. So if we look at the ordinary logistic, which, by the way, that is developed without any weighting. So this is just logistic, no importance weighting, no stratification. We see we get an AUC of 0.745. If we use the importance weighting, we get 0.777. And with the propensity stratified, we're getting 0.783. And those are statistically significant differences based on the long test, or you just look at the confidence intervals and you can see. What I'm going to do as well is I'm going to compare to an XGBoost model that was optimized on the training set and then predicts on the various test sets. So that's this result, which is 0.815. Now, the XGBoost model doesn't have any weighting at all. It's just using the training set and then predicting on the test set. So what we would, one of the things we'd like to be able to do is develop an interpretable model, logistic, that gets as close to, say, XGBoost, because this is one of our best. And I should say it's not just XGBoost, it's gradient boosting in general. If you use other formats like GBM, you get the same results. They're very comparable. So what we can see here is big improvement, but still a big gap to how well we could do with gradient boosting. Okay, looking at this on the Oregon data, same endpoint, and we've got the same phenomenon. We see that we've got big improvements. In this case, there's a slight advantage in the propensity stratified over the importance weighting, but we can see they both have a big advantage here. But once again, there's still a pretty big gap between what we can do with XGBoost. Okay, sepsis model on Utah, same sort of results. They're a little closer. There's 0.762 versus 0.785. And for whatever reason, the propensity stratified logistic didn't do as well, but it's still statistically significant difference from the ordinary. And once again, we've got a gap with the XGBoost. But the point is that we can stay with logistic and get something that's interpretable in giving us better results. Okay, 90-day sepsis on Oregon data. Same thing again. These actually get much closer to the XGBoost for whatever reason. And then major cardiac event is just, this is a combination of acute myocardial infarction, stroke, and chronic heart failure. So it's combines those three into one. And once again here we do see this an advantage, and these actually got close to XGBoost. So one of the interesting things, so did I skip one? Oh, yeah, it doesn't matter. Okay, so you get the idea. There's a lot of different results. Another one we're looking at is diagnostic coronary catheterization. So whether or not within 90 days after being admitted, someone needed this procedure. And we can see here's one with a huge difference. One of the interesting things is that the ordinary logistic, you see where it's like it's having this problem once with sort of the higher sensitivity, higher specificity range down to lower specificity range, but it's just this strange shape here where it's flattened out. And what the importance weighting is doing and the propensity stratification is doing is actually capturing that regime a lot better. So one thing, so we see here that we've got big improvements, but still a pretty big gap. And then looking at the same on the Oregon data, once again, we see this sort of strange flattening here that doesn't occur when we look at the importance weighted logistic and the propensity stratified logistic, right? So once again, sort of what these methods are doing is they're trying to focus most of the training effort on data points that look like what you see in the test set, right? Not based on the endpoint value because we don't know it, but based on the joint distribution of covariates, while down weighting points that look a lot different. So it's focusing its efforts on points that look the same in what you see in the test set in an attempt to actually improve your performance. And so we see here we get big performance gain again, and some of a gap, sort of a gap still with the XGBoost. Okay. So one of the things, and this, when I had submitted my abstract, I hadn't really thought about this approach yet, but I started to kind of think about this. So it's good, right? We have good results. We're able to get better results, and everybody's happy, except that one of the things that bothers me, maybe it's not easy to get. Sometimes we won't even have a sample, right? And of the test data. And the other thing that bothers me is that for each different hospital system to which you need to apply it, you theoretically need to develop a different model. And is this really scalable from a business point of view? Is that practical? And so it sort of made me ask the question as I started to look at things, why does this XGBoost, which is built on the training data alone, but we don't have any information about the test data, why is that generalizing so well? We're not hitting it with importance weighting or anything. It's just taking the training data and it's generalizing. And the conjecture is that it has to be discovering important nonlinear rules, so interactions between the features that also apply in the test set. And the logistic model just doesn't capture those. It's not it doesn't have interactions. So the question I had is, what if we could incorporate some of the rules that we get from the a boosting model, boosted trees, into logistic models? So I did some research, and it turns out that such an approach does exist, and it's called rule fit. So really what rule fit does is it combines gradient boosted trees, random forest, just some method for developing trees. And when you think about it, what is a tree? It's just a list of rules. So if x1 equals this and x2 equals that, then here's your outcome. Here's your predicted value. So the idea behind it is that you build a gradient boosted tree ensemble, you extract rules from that tree ensemble, you map those to binary variables that are equal to 1 if the rule that you extracted if the conditions for the rule is met, and 0 if it isn't. And then you augment your data set. You have your original predictors and you add to that those rules. And then you develop a logistic model on that. But because you have thousands of potential rules, you use something to select down the number of rules so that you're not overfitting. So something like a lasso, or you could use elastic net, but just a method to enforce sparsity. And the idea then is that you get an interpretable model. It's still just going to be logistic, but it's going to have some rules that are, maybe involving interactions of whatever depth you want to allow in your model. So I'm going to show some results doing that. In what follows, we have 100 trees. I'm just using 100 trees to generate rules. I put an upper limit of 300 variables, rules combined. So the original variables plus rules on top of it, in case lasso otherwise selects more. And I also limit the rule length to 3. So that has interactions of up to 3 for the variables. So it could be that your age is greater than 75 and you have this condition and you don't have this condition, right? Something like that. So here are some results, and let's look at the respiratory failure. So if I look at the rule fit on Utah for that, I get a 80.8% for the AUC. Now let's compare to what we did with the importance weighted, 0.777, propensity stratified, 0.783. I'm also putting in logistic with lasso because I wanted to make sure that, so this is the logistic on the original training set with no weighting. And I have lasso because I wanted to make sure that it wasn't just the regularization that was giving us the benefit here. It was actually the inclusion of rules. So then we get the rule fit, which gives us 0.808, and that brings us much closer to the XGBoost. Likewise on the Oregon set, we get the big gain. And we actually recover what we got with XGBoost. And then I'll do one more example, which is the diagnostic coronary catheterization. So here we see that, once again, logistic with lasso, maybe it gave you a little benefit, but it can't explain the gain that we got from the rule fit. So it's not just the regularization and trying to sort of, downweight coefficients or even leave out variables that maybe were causing overfitting that's given us this boost. It's actually the inclusion of the rules that we're getting from the boosting. And likewise with when we apply it to Oregon, in this case, it does the same as we get with the importance weighted logistic, but it's a good thing. So let me just sort of give some conclusions here and cautions and talk a bit about the future work. So the importance sampling does help with the generalization to the Utah and Oregon data sets. Likewise, the propensity stratified logistic models do help, and they may be more robust because you don't have to worry about this, the importance weight blowing up on you. You're just doing stratifying according to predictions of belonging to the test set. However, I think that the rule fit, at least based on what we have here, it may be a better example. Clearly, better way to go. It clearly generalizes well. It gets us closer, for most cases, to the XGBoost, which we know is a very sophisticated approach. But the real advantage is it doesn't require the sample of target test set covariate data that we would need from if we wanted to use importance sampling or the propensity stratified logistic. And the big thing from our point of view is that we don't, if we don't need to develop separate models for each target set, right? So that's a real advantage. Now, granted, these conclusions are based on limited target test sets and endpoints, and in the process of doing a lot more. Clearly, and I should say we should carry out other analysis with other metrics. I've done a lot of that, and we really do see the gains in using the importance sampling, the propensity stratified, or the rule fit. In other metrics of interest, PPV, sensitivity, lift, net benefit. Something that comes into question is what about calibration? How well calibrated are these predictions? And the answer is it's not obvious that doing any of these approaches actually helps with calibration. My experience is sometimes it helps on the test set, sometimes it helps, sometimes it doesn't. So a lot more work needs to be done there. Obviously, we can include a lot more features. We could have procedure codes and prescriptions, but one of the things. And how am I doing for time, by the way? Am I doing okay?
I still have 1 minute.
Okay, good. I'll stop very quickly. One of the things, and this actually gets to a question you asked right at the beginning about data sources, and combining EHR with other sources. If you want a model that you want to be able to scale up like we do, and we want to be able to apply to different hospital systems, you really need to be basing it on data that you have available, that's readily available everywhere, right? So the diagnosis, the EHR, the Medicare data, that's readily available. When we do have specific cases of lab tests and other information like that, sure, we end up getting a boost in our models, but it's not like we can then take that and apply it elsewhere, because we have no guarantee that's going to be available, right? And one other thing that we really like to be able to do is include temporal information. So as you've noticed, yes, I had a little bit of history here, 365 days, 90 days admission. But the fact is, for some patients, we have going back years, we have a whole history of their diagnoses and their procedures and all this information that should be able to be exploited in order to develop more accurate models at the individual level. So with that, I will stop.
Thank you, Dr. Jordan. We do have 40 seconds, 1 minute to get questions. Feel free to unmute yourself if you have any questions for Dr. Jordan. If not, we will save your hold on to your questions to the end of the session, and we will have further discussions with Dr. Jordan. Next, we have Dr. Kerry Altoff. Dr. Altoff is an associate professor of epidemiology at Johns Hopkins Bloomberg School of Public Health in Maryland. She's one of the two principal investigators for the North American AIDS Cohort Collaboration on Research and Design, NA-ACOR, which is a collaboration of over 20 longitudinal HIV cohorts, both clinical and interval, which are relying on electronic medical record data and data collected via research study visits for analysis from most of the cohorts. Dr. Altoff's area of expertise are the physical and mental comorbidities and multimorbidity in adults aging with HIV. Today, Dr. Altoff will be sharing with us on her work titled Impact of Discontinuity in EHR Data Pipelines on Inferences that are Contingent upon SARS-CoV-2 testing or vaccination data. Let's welcome Dr. Kerry Altoff.
Thank you for that introduction. I'm going to share my screen. Can you see it?
Yes.
Thank you. Let's put it into presenter mode. So, come on. There we go. Okay, hold on one second.
We can look at this. Yeah.
Let me try one more time. Can you see it?
Here we go. Yes.
Great, thank you. So thank you everybody for showing up today on a Friday afternoon. I am pleased to present our talk today on the impact of discontinuity in EHR pipelines on Inference. So I just wanted to be sure to acknowledge the co-authors of this study, as I am the representative, but could not be up here without this incredible team. You'll notice that we have people from 5 different locations and institutes all over the country: Kaiser Permanente Mid-Atlantic states, Kaiser Permanente Northern California, the Veterans Aging Cohort Study, the Veterans AIDS Cohort Study, the University of North Carolina, Chapel Hill, and Vanderbilt University Medical Center, as well as an amazing team of epidemiologists and biostatisticians. Within the NA Accord, we borrowed them for this collaboration that we call the CIVITS collaboration. So these are just some of our investigators in the NA Accord. These different teams were able to get very quick access to their EHR data in a very timely and updated way to build out some new cohorts. So we were able to pull together and work through the data pipelines. One of the very first things we did in order to understand where our data were coming from, and importantly, where they might be a little soft or weak, and how to patch those holes. And then, of course, a huge thanks to the National Institutes of Allergy and Infectious Disease, and specifically Carly Williams and Rosemary McCagg for funding this work as a supplement to the NA Accord. So what do we know about SARS-CoV-2 data pipelines? Well, I think everybody here probably knows to some extent they're complicated and they were evolving. So when we're specifically talking about the data elements of COVID testing and COVID vaccination status, we know that this happened all over the place in our communities, whether it was with a healthcare provider or a government or health department clinic, commercial businesses like grocery stores, pharmacies, they were administering tests and vaccines. Schools and nursing homes are just some of these locations. So really the information that we wanted to collect was out there. Our state in Maryland and many states across the country did require COVID testing and COVID vaccination status to be sent to state level registries. Some areas were lucky enough to then have that information sent to a health information exchange. So one here in the Mid-Atlantic is called the Chesapeake Regional Health Information Exchange. And so this group was able to pull together data and information from the states that are all right next to each other, and in which people cross state lines to receive care. For example, somebody in the District of Columbia may be receiving care in Maryland through a Kaiser location. So we had these multi-state health information, or HIE, exchanges. And the question was, okay, everybody had to put data into that location, but how do we pull data out of that location for a health system to, number one, complete their records for their patients? Because of course, COVID status as well as vaccination status is really important clinical information for your clinician to know. But then also, if we're going to use that EHR system for research purposes, we need that data in the EHR so we can then abstract it along with a bunch of other information about those individuals. So as time evolved, many places saw daily automated pushes of data from a health information exchange or a state health department, some other sort of state level registry, into healthcare systems who requested it. Then there was this whole process of making sure it wasn't just in the back door of a health information, of an electronic health record, but rather was auto reconciled. So instead of a clinician having to go and reconcile it into a part of the EHR where we could abstract it, it was just automatically uploaded for test results into the microbiology tab of the EHR. And then the same was true for the state immunization registries and the multi-state health information exchanges, pushing data into those EHRs, but it was at a different timeline. Most of the time it wasn't daily, it was more along the lines of weekly. And in addition to that, oftentimes we saw physicians trying to pull that data themselves when caring for patients, because of course, immunization status was so key in caring for patients during COVID. So we knew that these pipelines were complicated. To be able to look across 5 different systems and really discuss in detail challenges that we're facing in finding the data and getting the data to flow through the pipeline effectively was very helpful, because a barrier in one location turned out to be a barrier in another location, but we didn't necessarily even recognize it as such. And some barriers were the complete opposite. They were not at all a barrier in certain situations. So we were able to really get a bird's eye view of assessing the quality of the data to start before we saw any individual level data. And this whole process of that bird's eye view and the thought process behind understanding where the data are coming from and how complete they are was the objective of this project that I'm presenting today. So we aim to explore the availability of the SARS-CoV-2 testing and vaccination data as an important preparation step for rapid assessment of breakthrough infections in people with HIV compared to people without HIV. So I'll talk about, just show you brief results on that, how this legwork in the beginning really helped propel us forward. We thought about data sources, we thought about pathways into and out of the EHR, and we really critically thought about situations where data were either challenging to extract from the EHR or simply are not recoverable in the EHR, at least currently. I feel like tomorrow this talk is dated, right? COVID moves so fast. And then, of course, we take this critical thought about whether or not differences in missing data are present by race and ethnicity. And we specifically did have a few projects that we were looking at disparities and trying to evaluate those. One of them is being presented here. It's a poster by Julia Serta from the Kaiser Permanente Mid-Atlantic. She's moved on to another organization, and we're thrilled that she was working with us. And her poster is differences in COVID-19 testing positivity and outcomes by race, sex, and health system in our large and diverse setting of a cohort collaboration. And the take-home message of her poster is that there are higher burdens of SARS-CoV-2 among Hispanic and Black patients. And interestingly, we did not see that disparity go away when we looked within integrated healthcare systems where financial barriers to care are much lower. And so, of course, there are other social determinants of health at play, but being able to see how much of those disparities were being driven by differential access to care, we were able to kind of look at that when we compared a system that is not an integrated system to an integrated health system with those lower financial barriers. So take a look at that poster. So one of the lessons learned, sorry, let me just get my place here. So just an introduction of our collaboration. So our collaboration is the Corona Infectious Virus Epidemiology Team, or CIVITS, We are a longitudinal EHR-based collaboration of cohorts. The integrated systems are Kaiser Permanente Mid-Atlantic and Northern California, and then the VACs. And these different locations for these 3 different integrated systems are in different places. The map you see here is the NA Accord, so not all of these cohorts are contributing. It is just the 5 in the boxes below. Our non-integrated systems were the University of North Carolina, Chapel Hill, and Vanderbilt University Medical Center, which were serving populations of folks around them. UNC actually became one of the leaders and shared a lot of information with Duke about COVID status and caring for individuals with COVID, their test results, their vaccination status. So that was a unique setup that we got to explore through our collaboration. So the first lesson we learned is that, of course, there's under-ascertainment of vaccination and COVID-19 test results. And we started to think about where the under-ascertainment could be patched. What sources could we reach towards in order to try and obtain a complete population level ascertainment? And so if we start at the top of this funnel, this inverted triangle, we see that health information exchanges across multiple states are probably as close as we're going to get to population level ascertainment. It should be noted, however, though, that if people traveled too far to a different state that is not in the health information exchange, we would not have their testing or vaccination data. Similarly, if someone was tested or vaccinated overseas. So we just have to recognize that even though we're trying our best, there are still going to be people who are misclassified as not having a COVID test or not having a vaccination, even though they did. They're just outside the reach of any system we could tap into. Then we have our state level vaccination and testing registries. We have our large systems like Medicare, Medicaid. We have direct agreements with outside providers. So some of our cohorts were establishing direct agreements with CVS, with Walgreens, so that they were getting direct communication from them regarding their patients and whether or not they were tested, and if so, what the test results were and whether or not they were vaccinated. Not all places have that, but some of our collaborators did. Patient-reported vaccination or test results, which I find a fascinating area. And more relevant today than what it was even 6 weeks ago with the flood of at-home antigen tests into the market, which we fully recognize now are largely under-ascertained or not ascertained at all in EHR data. And then finally, the health system and health administered vaccines and labs that are, of course, right there in the EHR in real time. Now, I love this pyramid, but I think we have to recognize that the bulk of the data that we actually see are the flip of this triangle, right? The bulk of our data are coming from health system administered vaccines and labs, and then we're supplementing those data with all of these additional sources as best we can, and thinking through the places where we're not supplementing them. That's okay too, but we just need to know where those holes are so we can think about their impact. So one way we think about this impact is we think about, okay, non-Hispanic white individuals, are they more likely to have health system administered vaccines and lab data that we are seeing in the EHR than an individual who is Hispanic or a person of color who may have needed to get a vaccine or a COVID test at a state administered site on evening hours or on a Saturday when the health system outpatient centers were not available due to work demands or due to other family obligations. So kind of recognizing and thinking through social determinants of health and hypothesizing whether or not there would be racial or ethnic differences in the amount of information we're seeing on individuals. So it leads us to this question, does vaccination and testing occur more frequently outside the healthcare system, again, where we get the bulk of our data, for certain people, for people of certain races and or ethnicities? So in locations where Hispanic and people of color are receiving vaccination from sources that are not as fully ascertained during our look in our study, we have to recognize that there is going to be an underestimate of vaccination status or of testing status among those individuals. And really how I kind of think about this is the higher the level of sources ascertained in our triangle, the lower the bias. So thinking through the different cohorts that we were able to interact with and thinking through where they were on that pyramid, how high up they could get, and then looking at somebody who, a different cohort who may not have been as high, and looking to see if disparities by Hispanic ethnicity and race are different in those two settings was really insightful for us. And we narrated the reasons why we thought these things were happening. And, you know, it really, we did everything from talking through those data pipelines again, and whether or not the data pipelines were leaky for different groups at different points, all the way to discussing, well, actually, overall, this patient population are individuals who are employed. However, there are also a lot of frontline workers or essential employees, and so they may have had higher risk. Thinking through all of those scenarios was really important to vetting how much of a disparity that we were seeing could have been due to a leaky pipeline, as opposed to what we want it to be attributed to in our studies, which is the true cause, whether that be a social determinant, health, or otherwise. The second lesson we learned is that there are going to be lags, and these lags, they change over time. So there's lags between vaccination or testing date, when a shot goes into an arm or a test swab is taken, and the date that those data are extractable from the EHR for our different collaborators. And these lags really changed a lot over time. It felt like every time we got a handle on our pipeline, something would change. And so it was constantly reviewing the pipeline. These lags were much longer at the start of the pandemic, but they're also long for new data elements that are happening right now. For example, right now we're trying to think through monoclonal antibodies. Where are they in the EHR? Are they there? If they're administered by the state, are they there? Where are they? Are they getting pushed in the back door and they need to be reconciled? Are different EHRs and different health systems automatically reconciling those? We're really thinking through all of that. And, you know, we're experiencing those delays when you look in the data and you say, I don't think there are only 5 people who have actually received monoclonals in our patient population. So we've been pushing through those. So the lags change over time. They were longer in the beginning for things like test and vaccination. Those lags seem to be pretty abbreviated. Those are well-oiled data pipelines. But when it comes to new data elements, we got to be aware that there is a lag. Lags are a function of the frequency at which the health system is connecting to whatever their sources may be. In addition, the pipeline lags are key to know where the lags might be. For example, the push of the information to the EHR, auto-reconciliation versus clinician reconciliation, and where those data are living in hopefully extractable places in the EHR. So what do we do about lags? We observe them, we quantify them, and we monitor the change over time. So this is just a distribution of the dates of vaccination. This is all hypothetical. And when we see that data teeter off, we know that that lag is likely artificial. I'm sorry, the teetering off is artificial. This is how we define the lag. And so we have to ask questions about those lags. So does vaccination and testing occur more frequently for people of certain races or ethnicity where the data are likely to be more lagged? So vaccination occurring in commercial pharmacies like the Walgreens, CVS, Publix, et cetera, those typically lag about 10 to 14 days. When we're talking about the Veterans Affairs data, there's almost no lag, right? Anywhere you get it, all over the country, if you get a vaccination, it's going to pop up in your integrated electronic health record. So it's much less. So we do a lot of comparisons to try and figure out lags. And that's one of the values of really looking at this across multiple health systems and integrated health systems. And then finally, we modify our study design. We want to exclude individuals from observation at the end of complete ascertainment to reduce the impact of that lag on the accuracy of results. And we previously published this in this paper called Mind the Gap. And it's really just about creating observation windows where you look at the number of observations within the context of increases or decreases in the number of observations, as well as a scaled attempt to look at the number of measurements per individual per time point, like month or year, in order to see how much data you expect to be there versus how much data is actually there. And here in red, I've just noted some jumps in the scaled and in the percentages. And what we see is that this very simple approach helps us to identify February is incomplete data. We're not going to be using that. Some cohorts may have this red bar at the bottom backed up to the end of December, beginning of January. But the bottom line is we really need to know the date through which our data are fully ascertained and as complete as possible, because including additional time at the end when we're systematically or differently ascertaining events at a much lower level can really impact results, and we don't want that to happen. So lesson 3, there's no capture of at-home tests in the results right now. And we discuss this a lot. And right now, the health systems are really changing. They're changing from policies of if to how they will capture this information because of how critical it is. And this hole in our testing data is only going to get bigger with at-home antigen tests. So EHR portals are available, and some individuals do use those to report at-home antigen test that's positive. How that information then makes its way into an extractable place in the EHR, as many EHRs do not really want to or have the capacity to put a test result that is not done in specific, like CLIA certified labs, right? So what we're trying to think through and even work with our system of where would you put that information to denote that's an at-home antigen test and it's a self-report by a patient. We even have some healthcare systems who are thinking about potentially having walk-in clinics where they administer the at-home antigen test and get that result in 15 minutes for free. So if people come and do that, then that information can be immediately put into a specific place of the EHR. So a lot of thoughts going on right now about how to recapture some of that at-home test result. I have to be honest, I don't know how that will turn out. We use test results, all at-home test results, antigen tests in my household all the time, just to make sure people are okay. We would report a positive test, as I think most people would, but not all. And what my healthcare provider would do with that information, I don't know right now, and I'm working with them to try and figure that out. So this is definitely a work in progress, and we just have to recognize we don't know what the answer is. Lesson 3. Oh, am I coming up on time?
You have 3 minutes.
Great.
That would be the Q&A session. So it's okay. We still have 3 minutes for your session.
Great, thank you. So lesson number 3, we're going to think about information on different access to these tests by race and ethnicity, out-of-pocket costs. The Biden administration just pushed out a bunch of tests, so that's a good thing. But thinking through those barriers and how they might be different by race and ethnicity is really important, and whether or not somebody is more or less likely to report, and if they have a healthcare provider to report to, is really important. So monitoring of at-home tests is very challenging still. We have an incomplete denominator of the negative test results. Those aren't being collected anywhere. So these are just places that we have to be mindful of as we conduct this research. The final lesson, lesson number 4, we do not have individuals that have not accessed care in our studies. So these results are not generalizable to that population, and that population may be disproportionately Hispanic or people of color compared to the underlying population in the geographic catchment area. So we have to be very careful about how far we go with our inferences, and we have to think through the impacts of these differential leaks by race and ethnicity on our research questions. We have to do that before we start reviewing results. So we have produced some results with all this legwork. We estimated the rate and the risk of COVID-19 breakthrough in people with versus without HIV across 4 of our 5 cohorts. It's about 109,000 individuals. And we found that people with HIV did have a slightly higher risk of breakthrough, but overall, vaccines work, and they work very, very well. Less than a 3% risk of breakthrough in people with HIV and about a 2% risk of breakthrough in people without HIV. We did match on age, sex, race, and ethnicity to better get at this difference by HIV status. We see it's about a 41% relative increase in people with HIV for breakthrough as compared to without HIV. And we were sure to list all of our limitations that I just walked through that we found during our data pipeline investigations and discussions so that we knew exactly how far to take our inferences. So we continued to push on our data pipelines as monoclonal antibodies we're trying to identify those. Convalescent plasma is also now approved by the FDA in specific settings. Hopefully oral antiviral prescriptions will be easier to ascertain the same way we ascertain other prescriptions in the medical record, but all of this is coming down the pipe. So with that, thanks to all the participants in this study and the NA Accord, the funders of which are here.
Thank you, Dr. Altoff. We do have one comment here. Yeah, a few minutes, very good time control. Dr. Williams says that in the chat box, you can see the comment.
Sure.
Yeah.
Is this from Carly?
Yeah.
Yes.
Hi, Carly.
Yeah, yes, Kerry. They just finished a trial and they found that, of course, at-home testing for viral load and PrEP levels were very, very helpful, and people really liked them. So we will be rolling out, more and more at-home tests over time. So figuring out how to validate and everything, that kind of data is going to become ever more crucial.
Yeah, I think the people who, really build out these EHRs, they have a lot of different ways that they can take data in through forms and different things that they can provide, and ways that individuals can upload those results on their own through patient portals, ways that clinicians can upload those based on patient report. It's all going to be really important with clear delineation of where that test took place, because I agree, people like to do things from the comfort and the privacy of their own home.
Thank you. To the interest of time, we're going to the next presentation. Really appreciate your excellent presentation, Dr. Altoff. Last but not the least, we have Ms. Diksha Gupta. Ms. Gupta is a PhD student at the University of South Carolina, Arnold School of Public Health. She's also working as a graduate research assistant on a project examining how social determinants of health screening in health systems affect healthcare utilization. She holds an MS degree in agricultural and applied economics from Virginia Tech, and MA degree in economics from University in India. Ms. Gupta's presentation is on implementing a social determinants of health screening and electronic health record-based platform to assess healthcare utilization and community health resource use. Welcome, Ms. Gupta. It's yours.
Thank you, Dr. Hung. I'll share my screen now. Okay, are my slides visible?
Good.
Okay, so good afternoon, everyone. Today I will be presenting my team study, which is based on a pilot implementation of a social determinants of health screening and referral tool in a healthcare system in South Carolina. I will be presenting the results of this implementation on healthcare use and community-based resource connections. Okay. So first, I would like to thank our funding and clinical partners, including the University of South Carolina Big Data Health Science Center, the Health Sciences Center at Prisma Health, and Care Coordination Institute at Prisma Health. I have no conflicts of interest to disclose. So before I discuss the details of the study, I want to talk a bit about social determinants of health and the challenges the health systems are currently facing in implementing social determinants of health screening. So social determinants of health are the conditions in an individual's household, workplace, or community that impacts their health and health outcomes. So conditions like financial instability, housing instability, food insecurity are examples of some social determinants of health that have been linked to poor health outcomes like diabetes, asthma, hypertension, as well as increased hospitalization and health resource use. So given the adverse impact of poor social determinants of health, health systems have been increasingly intervening on these social determinants of health through clinical community collaborations. One example of such collaboration is the Accountable Health Communities model. In the Accountable Health Communities model, the needs of Medicaid and Medicare beneficiaries are being addressed through social determinants of health screening and community-based referrals. However, there are still several challenges in implementing social determinants of health screening and interventions in health system. First, there is a lack of evidence base about which social determinant of health to capture and which screening tool to use. So the lack of evidence base may be due to lack of awareness in health systems about the needs of the patients, either due to the hesitancy on part of the provider to ask sensitive social determinants of health questions, or due to the lack of training and resources available with the health systems to intervene on them. Moreover, while some health systems have started using electronic health records to enable screening and referral processes, the social determinants of health are not being universally identified through electronic medical records. Secondly, there is also a lack of standardization of social determinant of health data mapping to ICD-10 codes. It is also unclear how long after a social determinant of health intervention should we see improvements in patients' healthcare use, clinical outcomes, and costs. There is also little evidence on the role that the patient comorbidities play in screening and referrals. So we address these challenges in our study, which is based in Prisma Health, which is one of the largest health systems in South Carolina, with over 1.4 million patients each year. So in 2020, Prisma Health piloted a digital screening and referral tool called NowPow to address the social determinants of health needs of its patients. So what NowPow does is it allows for integration of electronic health records within screening information of the patients using medical record numbers. So the study population for this study included Prisma Health patients who were at least 18 years of age and were engaged in one of the 3 care programs at Prisma Health, which was community health, or what is also known as accountable communities, inpatient case management, and ambulatory care management. So these patients were screened for social determinants of health using a 13-question survey in NowPow. And if the NowPow returned a positive screen, patients received a list of referrals to community-based resources or services from providers. And these resources were curated by NowPow and were tailored to patients' needs and demographics. NowPow also allowed for closed loop referrals, which means that providers were able not only to send information to referrals to community-based organizations, but also were able to receive information about the referral outcome. So our study had 3 aims. The first aim was to create a linked data set of NowPow referrals and electronic health records via NowPow for research purposes. We also wanted to examine the demographics, comorbidities, and social determinants of health needs of the patients who were receiving the referrals. And using the linked database, we also wanted to investigate the characteristics of clinical users, which were mainly providers, case managers, and social workers who were making referrals to the patients, including their uptake of NAPAO, and the volume and type of service referrals that were made. So the NAPAO data included screening information, including the patient's needs, social determinants of health needs, and the type of referrals they received, as well as electronic health records, which captures patient demographics, their healthcare use, and comorbidities. The study period for our study was June 1st, 2019 to December 31st, 2020. And patients were included in the study sample if they were at least 18 years of age, if they were Prisma Health patients in Midlands or upstate regions of South Carolina, and if they were engaged in one of the 3 care programs at Prisma Health, which were ambulatory care management, inpatient case management, and community health programs. So this table is a description of the 13-question survey that was used within NAPAO. The survey was developed from validated questionnaires such as the Hunger Vital Sign or PRAPER, and included questions from various social determinants of health domain, such as food insecurity, housing instability or quality, lack of transportation, social connectedness, and so on. So these screening questions were based on the patient's needs that were known to the health system and the resources that were available with the health system for intervening on these needs. We include, and as you can see, some of the questions are highlighted in the table. These were the questions that were included in our main regression analysis to avoid multicollinearity issues. So we had 4 main outcomes of interest and therefore 4 different regression models. The outcomes were difference in visit types before and after the index screening date, which was the first screen date for a patient. And we were interested in differences in emergency department visits, differences in inpatient episodes, difference in inpatient length of stay, and difference in primary care physician visits. The model specification for each of these regression models remained the same, and the independent variables of interest were the number of social determinants of health referrals to the patients, the number of comorbidities, the response to screening questions on food, housing, transportation, and other domains, patient demographics like gender, age, and the region where the screening had taken place, which was either Midlands or upstate. So initially around 2,723 patients were screened at Prisma Health from April 2020 to December 2020. However, 36 of these patients were excluded from our final sample because they had answered an earlier format of the survey, which did not map to the 13-question survey that we had used in our study. So finally, there were 2,687 patients in our final sample. Of these, about 1/4 of the patients were screened positive for social determinants of health needs, and majority of the patients who were screened positive received a single service referral, which was also called an ERX, and a very small proportion of the patients received closed loop referrals. But that was because information was still being collected about community-based referrals at the time of the study. So coming to the study results, we found that the mean BMI of the population was high at 31.9, and the mean age was 62.9 years. A majority of our population was female, white, preferred English as their language, and had Medicaid as their primary payer. Only 17% of the patients were smoking at the time of the screen, and about 1% of the patients were pregnant at the time of screen. And most of the screening took place at in upstate Prisma Health. We found that almost half of our sample had diabetes. Other diseases that were prevalent in our patient sample was chronic pulmonary disease, cerebrovascular disease, various types of cancers, and heart failures. Moreover, on an average, patients had about 2 comorbidities present at the time of their screen. So our results on resource use and screening data indicate that the mean number of screens per patient was around 1. The mean number of referrals to community-based organization for each patient was around 10 referrals. And the mean number of social determinants of health categories for these referrals were around 2.47. We also conducted pair sample tests to see whether there was a difference in per month visits or episodes before and after index screen. And we found that ED visits and emergency department visits and primary care physician visits increased significantly after the first screen. But there were no significant differences in inpatient episodes or inpatient length of stay. We also assessed the distribution of needs categories and service referrals. So a person could have multiple social determinants of health needs and could also receive multiple referrals for a single need. We found that the patients had the most needs for food and nutrition, financial stability, mental health, and exercise and recreation. We also found that the most common referrals were to services such as SNAP registration assistance, food pantries, fresh fruits and vegetables, individual counseling, and so on. So coming to our main analysis, we used ordinary least square regression for our analysis and also tested our models for multicollinearity. Our results were robust and we found no multicollinearity in our model. So I have 6 slides on regression results, but I want to mention here that they are the same regressions, just the independent variables are mentioned in different slides. So we found that the number of referrals was significantly associated with difference in primary care physician visits per month, and that an increase in a single referral would lead to a decrease in primary care physician visits each per month by 0.063 after the first screen. We also found that an increase in a single comorbidity in a patient increased their healthcare use except for primary care physician visits. We did not find any significant association between patient responses to the screening questions and resource uses. So for questions on like food insecurity, we did not find any significant association. Similarly, for questions on housing instability and transportation, we did not find any significant association between the responses and the type of differences in visits. However, for patients who had answered some of the time to the question on social connectedness, which was how often do you feel that you lack companionship, we found that they had significantly fewer primary care physician visits after the screen than patients who had answered that never to that question. We also did not find significant association between most demographic variables and resource use, except for age. So age was associated with a larger increase in primary care physician visits after the first screen. Similarly, we found a significant association between inpatient episodes and race, particularly patients who identified as Black had a greater decrease in inpatient episodes after the first screen than those who identified as white, but there were no changes in ED visits, inpatient length of stay, or primary care physician visits. Interestingly, we found that although multiple referrals were significantly associated with a decrease in primary care physician visits, this effect was moderated by the number of patient comorbidities, as we see from the results of the interaction term. We also analyzed user information. We found that there were 60 users over a period of 9 months of implementation of NowPow. We found that the addition of new users increased in the initial months of implementation, but declined during the later months. We had categorized the users based on the total number of referrals or ERXs that they provided to the patients during the study time period. The mean number of ERX per user was 12.6. So users were classified as high user or low user based on the mean. And we found that there were 18 high users and 42 low users. We found that the proportion of high users decreased towards the later implementation months compared to the low users. We also assessed the distribution of referrals after the implementation by user type. We found that the mean number of referrals per month for all users remained stable throughout the implementation and was around the value of 3. However, for high users, the mean number of ERX per month increased during the initial months of implementation and then remained stable. But for low users, it remained consistent throughout. So our study has a few limitations. Firstly, since it's an observational study with only a single group of patients, we are not able to establish causality between our independent variables and differences in visits or visit types or episodes. Moreover, our study results may be confounded by the increase in infection rate and hospitalization due to COVID-19 that had occurred around the same time that the screening took place. Second, we assessed only 9 months of patient and user information since implementation, which may not be sufficient to see changes in resource use. There were also system level changes in EMR vendor, which limited availability of some records. Our results are also specific to some of the patient groups and may not be representative of health system patients. Moreover, we had poor records on language preference. We had records for only 50% of the patients, majority of whom preferred English as their primary language. So to conclude, we found that patients had highest needs for food and nutrition, financial instability, and mental health. We also found that multiple referrals are important for reducing healthcare use, particularly primary care use, but may be moderated by number of patient comorbidities, which increased healthcare use, as was shown in our results. We also found that NowPow uptake remained consistent among users over time, and our future work on NowPow aims to assess how distance of patients' home from emergency department affects their visits after screening, and how and we'll also include geospatial analysis to identify the communities with the highest referrals and their characteristics. So that was all from our study. Thank you so much, everyone, for your time.
Thank you, Diksha. We do have 6 minutes for a few questions, and we're going to. So I'm gonna go through a few ones that were not answered. Feel free to add your questions on chat box, so you unmute yourself. The first question was to Dr. Liu. Did you consider difference for the pre-post pandemic racial disparity? What was the level of?
Okay, thank you, Theo, for that question. I think the main reason we didn't do this difference is basically SSM rate is pretty low. You know, what I presented there is like per 10,000. And so I don't know whether we really have that capacity to be able to look at difference between, you know, racial disparity and then cross two time periods. So, you know, looking forward to get more suggestions. That's why we did not do that DID methods.
Yeah. One way is to use interrogatory time series. So we can see the sharp change and pre and post trend, and our team is working on that. Yeah, thank you. So next question, I'm gonna post it here. Feel free to add your questions. So Dr. Jordan, it put this there. If you Do you mind sharing your expertise on how to apply your methods to detect or identify robust treatment effects, especially heterogeneous treatment effects of some interventions? We know your focus was the prediction for the health outcomes. Was there a way to really test the robustness of the betas, the coefficients for some specific variables?
Yeah, no, I'd have to, so I have to think about that. I'm not entirely sure. So that's my honest answer. It requires thought, but it definitely is something I would be interested in talking about. And,
Thank you, Dr. Jordan. Yeah. And then the next question is to Diksha. Yeah, you answer them. Do you want to elaborate that, Diksha, and repeat Michelle's question? Did you test multicollinearity for your models?
Yes, we did check for multicollinearity issues in our model. We found that some of the independent variables that we were considering did cause this problem in the model, and we selected our screening questions based on to ensure that there were no multicollinearity issues in our model. We found that the VIF was less than 10, so our model was did not have any multicollinearity issue.
Awesome, yeah. Dr. Chow has another question. I bet this is for you as well. Would you like to clarify that if this Determinants of health screening is conducted for every visit, or this is just conducted at the baseline?
So the screening was conducted for every visit. So we had patient records for their responses to the screening question at every visit. However, for the purpose of our analysis, we considered only the first screen as the index screen to take the measurements of differences in visits or episodes. And if there were like multiple screens during the same day, we selected the the time of the last visit as the index screen.
Great. We still have 1 minute. I think 30 seconds. So that's just conclude this session for today, Electronic Health Records Breakout Session 2. Tomorrow, we will have another day of very educational conference, including poster. Make sure you check out poster Dr. Altoff colleagues is presenting in terms of the very interesting COVID data and all those pipelines. All right, this concludes our session, and thank you all for excellent presentation, and thank you all for your participation. See you tomorrow.